morning, everyone, and happy Friday. Happy first day in a while that it's felt like fall. And yeah, the beginning of October, so how timely. Today, we are going to start off and welcome Dr. Stanislaus to provide us with some updated information regarding COVID and what's going on in Missouri and what we can do in order, and what we need to know in order to best help protect the health and safety of those that we serve. And so, Dr. Stanislaus, as always, we really appreciate your willingness to join and provide the information.
Thank you, Jess. Two things that's new this time is that last week we got the FDA and then approval, followed by CDC's blessing to start the booster dose. So there's always some confusion or something different between, people have asked this question again and again, what is different between the third dose and the booster dose? Okay, the booster can be the third dose. Why do we call one dose third dose, and why do we call another one the booster dose? So the way they have defined the third dose versus booster dose is the third dose is for individuals who are immunocompromised, which was approved a month earlier by the CDC and FDA to go ahead and give, especially for Pfizer and for Moderna. So the Moderna and Pfizer both are approved for the third dose for those who are immunocompromised conditions. We talked about it in the last webinar on that. The booster dose is currently only approved for those with Pfizer. So those with Pfizer, if you've already had 2 doses of Pfizer and it has been 6 months since the second dose of Pfizer, then you're eligible for your booster dose. And the individuals who are eligible for the booster dose, among other things, are healthcare professionals. So they have clearly stated if you're 18 and older, and if you are a healthcare professional, then that is considered one of the high risk worker or essential worker category that has been approved for the booster shot, especially Pfizer. It is not available for those who have taken Moderna or those who have taken the J&J. Moderna is working on something along the lines, and we should be able to hear that something within the next month. J&J hasn't said anything, but there's a possibility as well. But at this current time, it's only for those individuals who have had 2 doses of Pfizer. So what are the 2 things to remember when you're going for your booster shot? One is that it has been 6 months, at least 6 months since your last dose. And the other thing to remember is if you've had COVID, exposed COVID, or had been hospitalized with COVID, and either you received monoclonal antibodies infusion or had got convalescent plasma, which is also called passive antibody treatment. If you had any of the passive antibody treatment, one is a monoclonal antibody and the other one is the convalescent plasma, then you should wait for 90 days before you can get the third shot. Okay, so that is what we have. There are other professions as well that fall under the one more. I'm just trying to find the questions also. So there are other things as well, other professions as well that fall under the essential worker category. And if you just Google it, you'll be able to find it. So I don't know them, all of them at this present time. I know teachers are part of it as well. So teachers and healthcare professionals are part of this category, but there are other category of individuals as well. So if you work with, how do you get the boost? How do you get the booster shot? My understanding is talking to some of the individuals who I work with, stated that they had contacted their local pharmacy, CVS, Walgreens, Walmart, Hy-Vee, whatever is your local pharmacy, call them, make an appointment, go in and get your Pfizer shot if you're eligible, if you're a healthcare professional and eligible to get it. So it has not been difficult. Most of them have been able to walk in the same day and get it. Now, if you are part of Department of Health, and you work for a developmental disability facility or one of our state hospitals, then we are doing it in-house on certain days. And so if, you would know by now which facilities are offering it. For these are just the state employees. But if you are working in the community, then the best way to get it would be to go to you just go to your local pharmacy and they should be able to get it. When you do go, take your previous Pfizer vaccination card with you so that they could sign it and put the information on the lot number in the same vaccination card, so you don't need another one and you can carry it. So I would recommend taking your vaccination card if you'd had Pfizer before and getting it done. I'm open to questions.
Okay, we had several questions come in, Dr. Stanislav. The first question is, for individuals who were COVID positive and either displayed symptoms or were asymptomatic and have since been fully vaccinated, but fall within the CDC suggested groups for the Pfizer booster, is the booster recommended? So that's the first part, which I think you've answered. But then it says, or should people who were sick receive the vaccine at all? And does the vaccine strengthen the immune system even more, or is it possible to tell via antibody testing?
Okay. So let's just Heike, can you do just the first question again so I can make sure I answered it correctly, and if needed, I will answer it again. What is the first part of the question, Heike?
The first part was for individuals who were COVID positive and either displayed symptoms or were asymptomatic and have since been fully vaccinated, but fall within the CDC suggested groups for the Pfizer booster. Is the booster still recommended?
Yes, the booster is still recommended, but it has to be 6 months. So let's say you became COVID positive in June or July, or let's say July, and then got the vaccination immediately after that. It's still after your second dose, you have to wait for 6 months to get your booster. The reason for this, some of the research that came out of Pfizer indicates that by 6 months, there's some drop in the neutralizing antibody level. And it is because of that reason, they think to boost up your immunity that was initially created by the Pfizer vaccine. That's the reason why we have the term is called booster. So it's just boosting up the antibodies, neutralizing antibodies up again by taking that booster dosage 6 months after the first. So yes, it doesn't matter whether you got COVID or you did not get COVID. The important thing is if you got the first 2 doses, dose 1 and dose 2, which is like 3 weeks apart for Pfizer, then you have to wait 6 months after the second dose to get your booster. What's the second question, Heike?
The second part of that is, should people who are sick receive the vaccine at all?
So when people are really sick, very, very sick, what they recommend is, let's say somebody's been in the hospital and very weak. So 2 things. One, if you're COVID positive, let me start it this way. So let's say that you are COVID positive, the individual is COVID positive, then you would wait the 10 days. The 10 days is the isolation period. That is the period of time when the viral proliferation has stopped and there is there is no virus that can continue to replicate, is by day 10. So you wait for the 10 days, and after your 10 days is over, from the day you tested positive or you became symptomatic, then you can go get the vaccine. You can get it at any time, immediately after those 10 days. And I would recommend getting it after the 10 days as early as possible, because you can still get reinfection. We've had individuals who've had reinfection within 3 weeks after their previous test, because before 3 weeks before their first infection, COVID positive, because the variants they're different. And so people have got it reinfected fairly quickly after. So my first question is, wait, when you're actively sick with COVID, wait till you are at least past the 10 days. And let's say you had to be hospitalized and you feel very weak, then I would wait another week or two to get the vaccine, because you just don't want, some people may have a little bit more tiredness and kind of feel a little feverish for a day or two after they get the vaccine. So, if you're already fatigued from the COVID, you want to wait a little bit longer to get the vaccine. So I would say, if you're really sick in the hospital and had been in the hospital and just recovering, don't put it too long, too far away, or don't push it too much, but at least give yourself a week or two after recovering to get the vaccine.
Okay. The next question, is it recommended to have antibodies tested prior to vaccination or the booster if you've previously had COVID?
No. The reason is the antibody testing has not been consistent and there has not been any clinical correlation. And this is where the problem is. The titers are not, there's no cutoff saying that if I had, like, for example, in diabetes, right? We know if the blood sugar is past a certain level, then you have diabetes. That means my blood sugar is not well controlled. I need more insulin, or I need to be treated with medication. We do not have that kind of correlation where the antibodies in COVID yet. It's all over the place. I wish that we had a good antibody titer and said, if your antibody titer was less than this amount, then, that means you don't have enough neutralizing antibodies, go get your booster. Or if you have passed this amount, this cutoff, then you're good. We don't have such a number or research to substantiate, and the reason is because the antibody production is related to so many other factors, and they have not been able to find a cutoff of the antibody titer to say, as long as you have this much antibody, you're protected. We don't have that. So doing antibody testing is not recommended at this point by the CDC or by any of the scientific organizations. And I don't rely upon it in our state facilities. So I would say if it is 6 months past your second Pfizer dosage and you're eligible for a booster, because if you work as a healthcare professional, go get it. There's no point getting the antibody tested.
Okay. Next question ties in with the flu vaccine. It says, would it be better to get the yearly flu vaccine now in early October and then wait a few weeks and get the COVID vaccination booster, or the other way around?
So initially there was people, they said that don't give two vaccines at the same time. Now, the new recommendation is that you can make an appointment for both the vaccines at the same time. You can get your COVID vaccine on one arm and the flu vaccine on the other arm. So there is nothing that says that you can actually get both of them at the same time. You do not have to wait or give any time between the first vaccine and the second vaccine. Whether it's flu first and COVID second, or COVID first and flu second. It does not matter. So you can go in for the same appointment at the same time and get it in two different arms. You don't want them at the same spot, but two different arms should work. Or if you want to go in a week, if you have time and you want to do it a week apart, that's fine as well. But there's nothing contradicting getting both those vaccines at the same time, at the same appointment, as long as it's done in two different sites.
Great. Are there any prediction models on flu strains for this coming year, and which strains are being vaccinated for?
That is always a hit or miss with flu. Usually based on the mutations, the influenza virus does, they know, typically there's a pattern, and the scientists who work on the flu vaccine typically are able, because of past history and trajectories, they are usually able to predict what is going to be the prevalent mutation that's going to arrive that particular year. Most times it has been accurate, but there have been years when it has not been accurate. We will not know whether the prediction is going to be correct or not until the flu season starts. because if it starts and then they see, well, the vaccine really did not match with the mutation that was seen, then, they got it wrong. But when the vaccine matches with the mutation, predicted mutation, then they got it right. So we will not know that at this time. We just have to wait for the flu season to arrive.
Okay, and one other question leads in with a bit of a scenario. COVID-19 has shown some predictable surges or increases in the past. Without being an alarmist or alarming, what might there be a predicted increase in cases in the next few months or future without serious intervention or increases in vaccination rates? Or will that depend on new variants or renewed strength/reintroductions of previous strains?
That is correct. So typically what we have seen is kind of a wave. So it comes in a new strain or a new wave, or the first one that came in was in the spring of 2020 was the original COVID virus, or the original strain that came from China. So that came in I think we had pretty much our first wave end of March, early April. And by that summer, we had it lasted a longer time. By that summer, it kind of went down a little bit later that summer, but then it didn't really go down very much. The second wave, really, we saw it increased around after Thanksgiving, around November, and then it lasted to December, January, February. It was really high in different areas of the country as well. So you see, for example, and it depends. The peak in different parts of the country are different, depending on the spread. And then we had some really low months. I think it was April, May, June were great months in Missouri. Our rates were so low. Vaccination had occurred, and we were all very happy that vaccination has prevented the increase. And, we were getting to some level of not fully normal, but to certain less restrictive lifestyle. And then Delta came along. And it was a completely new, very potent virus, very contagious virus, multiplied very quickly, was highly infectious, and people are getting sicker quicker and sicker and more sicker. And that lasted. It started in July, first week of July, August, September, October. Now we are beginning to see a downward trend. Again, it's just beginning in Missouri. There are still pockets where you're still in a high increase. The pockets that we're seeing the increase are southeast, especially Poplar Bluff, Cape Girardeau area, Farmington. So we're seeing some southeast pockets of area where the rates are, but they are peaking now. They did not have the big peak when Springfield and Joplin were swamped with the Delta. Their numbers in Springfield and Joplin area has gone down, and central Missouri has also gone down, but the south is picking up. So once that picks up and then goes down, we'll see an overall decrease in the state until another variant comes along, which is more potent than, or more virulent and more infectious in Delta. I think Delta is going to be dominant for some time to come, even though there are other variants like Mu and R1 out there who do have some very very strange mutations that could be considered, that could escape the vaccine. They're not as infectious as Delta. Delta is the most infectious one. I mean, Delta, for every person who's infected with Delta, they can transmit to another 6 or 7 individuals. Whereas when the original virus was only about 3 individuals, and then Alpha was about 4 or 5, a little bit more, but Delta is definitely much more infectious. So not only if a new variant has to come, it also has to be more, it has to replace Delta. So it's, again, you just have to wait and see what happens. There is just no prediction, because this virus is so smart, so much smarter. It will do whatever it takes to keep infecting humans over and over again. It'll keep changing. And as long as there is someone who's immunocompromised and whose body doesn't fight the virus very well, it can go in and stay in there for longer and mutate. And that's how it mutates. So that's why we believe that good vaccination, if everybody's vaccinated and the numbers are really high in vaccination, then we don't give an opportunity for the virus to enter our bodies and mutate and make all the changes, because they are fought immediately. The antibodies in our bodies will fight them immediately, that they don't have an opportunity to sit there and mutate. So only time will tell, but that was a great question.
Okay, next question. Is the flu vaccine and COVID vaccine guidance regarding being able to get both vaccines on the same day different for pregnant women?
For pregnant women, I don't believe so. But if you, as I said, if people want to be cautious, I mean, that's a question with the pregnant women. The question I would say is just check with your OB-GYN. And if you're pregnant, just check with your OB-GYN to see whether it is safe. I'm not an expert when it comes to pregnancy. So I would definitely, I'm not an expert when it comes to anything really. But especially with the pregnancy, check with their OB-GYN and then make the decision whether you want to take both at the same day or you want to space it out.
And one last question is regarding COVID tests. Were the COVID tests recalled that are still being used?
Are COVID tests being recalled or still being used? Can you give me a little bit more context to that? Is that meaning that are they past the expiry date, or they're not useful anymore? I'm not clear on the question.
I'm not sure either. I will watch for this individual to provide additional information.
Yes.
And then we can always reach out directly too.
Okay. I just need more information to answer that question.
Okay. And I believe that is all the questions that we have.
All right. Thank you all. Have a great weekend. And now I pass it on to Station MD, Dr. Trivedi.
Thank you, Dr. Stanislaus.
Thank you.
Dr. Trivedi actually will not be on the call today. My name is Ariana Anderson. I'm also with Station MD. Just here this week, again, to just remind you that you can call Station MD for really any reason. There's no call that's too small. And I know that there was a lot of talk just now about the cold and flu season is upon us. It's the first day of October. So if there's any concerns, questions related to symptoms, if it's a cold, if it's the flu, if it's COVID, that's definitely a reason to reach out to Station MD. Don't feel that a call is too small to call for. Really, anything, any medical question or concern, we're available. It's just that 1-877 number, and 24/7 you'll be able to get a Station MD doctor to help resolve your concerns. That's just the big update from me for this week. If there's any questions, I'm happy to take them now or answer them in the chat. Okay, with that, I think I pass it off to you, Jess.
Thank you, Ariana. I really appreciate you making the time to join us. And the memo regarding Station MD should be coming out soon to service coordinators, and explaining the process now that we're in the waiver. And there's great news because the process will be seamless for those that we serve. So families, clients, caregivers still can directly call Station MD anytime they need them, despite not having an authorization already in place through the waiver. We didn't want that to change. We want everyone to just be able to make the call, and then we'll take care of administrative things on the back end. So that is just something I wanted to mention, and again, really appreciate you joining us. Okay, I had a few updates that I wanted to share with everyone, and the first one is regarding reimbursement rate, and that is the rate studies that we have been talking about for a couple of years, probably now. First, in terms of the residential rate study, which many of you are familiar with, most of you, And so the rate changes that were made to the residential rates in the most recent legislative session and previous were based on the rate study conducted by Mercer for those rates. And we have been working as an agency with Mercer to work through the rate studies for the remaining services that are offered through DD waivers. And that is being done in order to make sure that we are paying a actuarial sound and a market sound rate for those services. And so as we completed the draft of those rate studies in partnership with Mercer, the next step will be that they are putting together a presentation and to talk about the factors that went into producing those rates, and that those factors will be reviewed by the Rate Review Committee, which is a part of state regulation, that those rate studies and reviews go through that committee. And so as we move into that process, we'll be sharing more information with you as we hopefully get good feedback regarding any necessary changes that might need to be made or updates from the Rate Review Committee so that we can move forward in getting a finalized draft of the rates and the rate studies for all of the other services that we offer, so we can have that information available to decision makers in the coming legislative session. The other thing I wanted to mention is that during the month of October, we will be, as a department, sending out appointment letters to the new statutorily created Missouri Commission on Autism Spectrum Disorders. And that commission, will have a big job, and that job is that they will be creating a roadmap for how Missouri is to move forward in order to ensure that across the lifespan of those with autism, we are providing the best possible services and that they have the healthcare, education, and support that they need to live their best life. I think everybody wants to say, I'm living my best life when they say that. So maybe that's just a new tagline for DD, that we help people live their best life. And so the commission has 25 members. It's a fairly large commission, and the work is done in 4 phases. And the first phase, the first year's report, which will be done throughout next year, will focus on the transition into adulthood for those living with autism spectrum disorder. So if you want to learn more about that, it's available on our website. And then the last thing I wanted to mention is that if you did not get a chance to read the report that came out from the Raise Family Caregiving Advisory Council, they had recommendations to Congress on improving support for family caregivers. And I really encourage you to go look at that and check that out. There were some great recommendations within that report. And with that, I will turn it over to Angie, who has some updates for us on, you have a perfect lead in there in the chat. It's regarding the enhanced FMAP.
Yep, I did see that. So, yeah, so we did have some rate increases that occurred at the beginning of this fiscal year, so July 1st. Those were day programs, so included day hubs, community integration, individual skill development, as well as some ABA services. Those rate increases have already been implemented, and the piece that we were waiting on were the rate increases for our standardization of our group home ISL services, as well as the 5.29% of the PA rate increase. So on September 21st, Centers for Medicare and Medicaid, they did approve for us to use that enhanced FMAP for the HCBS rate increases for the rate standardization and that 5.29%. So that impacts the group home, the ISL and group home RN and LPN, as well as that personal assistant 5.29% component. So you should be seeing an email blast come out today with a memo attached to that, just kind of sharing our logistical approach to those rate adjustments. We do have to go back to July 1st, so we're taking kind of what we call a two-prong approach. We first want to make sure that the future billing is in line with that enhanced FMAP plan, so we don't have to make any additional adjustments beyond September of 2021. So we are in the process of adjusting all the rates effective October 1st. And then simultaneously, we're going to be developing that specific methodology to reprocess all of the billings from July 1st through September 30th. So, and we'll strategically plan those rebillings because we want to make sure that we're expediting it, but at the same time, we want to ensure that all of those rate adjustments are made and those voids and rebills for them to occur on the same cycle. And we really want to make sure that providers see that increase and they're not adversely impacted by mistakenly do a void and not the rebill of it. So we'll be strategically planning out that process. We are asking for providers' assistance just to help us to expedite that process. So as of October 1st, and again, this will all be outlined in the memo that's going out today, but as of October 1st, we're asking providers to not enter any units or census into CMOR until all the service rates have been adjusted. Like I said, we're in the process of doing that, and we will keep you posted and provider relations will let you know when it's ready to go. If you start putting those in there on October 1st, it causes a pause in the process and CMOR will reject any pending claims. So then we have to have you go back and manually adjust it again. So we want to make sure there's no claims out there in pending status while we're trying to update those rates. And that includes entering any units for July, August, and September services. So if you can just hold off on that too. We don't want those to get caught up in that void rebilling process. So again, we just really appreciate your assistance with this. We're excited, really excited that CMS approved it. And we're working as quickly and diligently as we can, just making sure that you receive those funds as quickly and as accurately as possible. You'll be working with our business officers who are working on it, as well as central office, and then the provider vendor coordinators. So if you have questions after you see the memo, you're welcome to reach out to them as well. And we'll continue to work together and keep you posted on exactly where we're at. So we are excited to be able to get this process for you. And I think that is all that I have. So let me make sure there's no more questions about.
Thanks, Angie. Yeah, I saw a few questions come up in the chat regarding the enhanced FMAP, and it was regarding exactly which rates were included in the enhanced FMAP that was appropriated for this year, which I know you mentioned was both residential and personal assistance. And so I did want to clarify overall that the enhanced FMAP received by Missouri is a total estimate of $216 million. And so while there were specific rate increases appropriated by the General Assembly for this year, this fiscal year that we're in, any further appropriations would have to go through the General Assembly during the next legislative session. So if they were to apply the enhanced FMAP to any future rate increases for other services, that would be during this next legislative session.
Sure. Yeah, I completely agree. There's another question here about the day habit employment services. I just want to clarify, they did receive rate increases. It was not using the enhanced FMAP. So those rate increases have already been implemented for July 1st. So, and then, okay, then I have another one about hold off on inputting authorizations for those services. Again, that's for your PA services, and it's for billings, not putting your billings in there. For PA services and the group home and ISL. And again, that'll be listed in the memo that's going out today. And community RN. So it's actually, so the question is, what are the changes to the community RN? You will see in the memo today, if it's the ISL RN, an ISL LPN, or for group home, those rates will have an increase. So you'll again see that in the memo. And I think that's all the questions. I think we've answered them. Okay, so with that, I will turn it over to Emily.
Hi, good morning. Give you an update with our waiver approvals. You might have seen the blast that came out from DD that CMS did approve the community support waiver on 9/22, the comprehensive waiver on 9/24, both with effective dates of 7/1 of this year, and the Partnership for Hope and the MoKids amendments to align with the renewal changes were both approved with effective dates of 10/1. And there is a link to that blast if you did not receive it. Thanks, Heike. She'll put that in the chat for us. And then we'd like to let everybody know to put the next step for us would be updating the waiver renewal manuals and also providing training to our stakeholders. And right now we're looking at October 12th from 9 to 10:30 for service definition training webinar. A registration announcements will be sent next week. Please note that when you register, event materials will be available, and materials include the presentation and a programmatic change chart. Let's see. I think we're not seeing any questions for mine. We might have some more questions related to the rate changes. So I'm going to hand it off to Wendy for an update next.
Good morning, everybody. I just real quickly wanted to thank those who attended the expedited UR process question and answer session yesterday, I believe it was. We had 122 attendees, and we really appreciate you taking the time to listen and ask questions and just confirm your understanding of how the process works. Please let us know at the ddmail@dmh.mo.gov if there are any other topics that you would like us to have a Q&A session on. We'd be happy to host that. And the one other thing that I just wanted to throw out there is I listened to a podcast today it's from Inside HCBS, and it is called Kenny's World, Person-Centered Planning. And I encourage you to get on Apple Podcasts and look that up. It was very good listen for people at all levels within the system, from state staff to executive management staff and providers and direct care staffs, just to remind us of how to be innovative, that we need to be always looking at the individual and how we can meet their particular needs. And that podcast was developed, if I'm understanding right, from the Center of Rehabilitation Outcomes Research. And I believe, Jess, as I hand off to you and wrap up, I think you might have a connection to some of that work. So it was very quality and very worthwhile.
Yeah, thanks, Wendy, for mentioning that. I had an opportunity to sit on the advisory council for some work that is being done by the Shirley Ryan Disability Lab out of Chicago. And they are doing some national research to advise CMS on outcome measurements for home and community-based services. But they do so many more things. And part of the work that they're doing right now is a piece of the grant as well, and that is a podcast to increase person-centeredness and awareness around person-centeredness. So anywhere that you get your podcast, you can search for Inside HCBS, Kenny's World, and hear the podcast. It has a really, first of all, you'll just fall in love with Kenny and the other folks on the call or on the podcast. But it has some really great insights into the balance between risk and independence, which is something that I think everyone struggles with. And so I just really encourage you to go out and check it out if you get a chance. And I will, and Wendy put it in the chat. Good deal, because we had somebody ask to defer the name. And I believe, let me look through some other of the chats here. Angie's waiting for me to pause so that she can answer some of the questions that came in. Thank you.
Yep. Do you want to go ahead and jump in on those, Jess? Sorry.
Yeah, that's okay.
I didn't want to jump in on anyone, so I'm going to scroll back up because there's several questions here. So the next one I think I had was, will the new rates for the community RN services be standardized rates? So we are working on anything that's covered under ISL and group home, which would be your RN and LPN. I always hesitate to say community RN because I never know if someone's talking about ISL or if they're calling PAM's community RN, two very completely different services. So I'm going to say ISL RN and the ISL LPN. We are moving towards standardized rates for those, but remember that because of our ARPA funding, we cannot lower anyone that is above the rate studies, the Mercer rate study standardized rate. So if you were below, you're going to come above. If you were, or come to the rate study. If you were above, you're not coming down yet. And again, that'll be in the memo as well. And if you take a look at that and you still have questions, let us know. And then there's another question here. Please clarify if they have an employment will receive the FMAP funding in addition to the increases that already occurred on July 1st. So as of right now, there has not been any appropriations from the General Assembly to utilize enhanced FMAP funding for DAHAB and employment. We do have some items, in our spend plan, but again, anything in addition to the current rate increases that we have would need General Assembly appropriations for us to be able to pass those along. So we will stay tuned to that. They have employments, do not have rates appropriate. Okay, so that's the same. Okay, Jess, you actually already answered that one, sorry. And then someone did ask if there's an increase in the maximum MoHealthNet payment for residential services. There, because of the recalculation that our system does, we are submitting over a new Medicaid maximum, and that was released in I think that was released in a provider memo earlier towards the beginning of the fiscal year when we updated that, and MoHealthNet sent that out. So that should adjust for the increased rates that we're having on the group home and the ISL. So we should be good there. If you cannot find that increased amount, let us know. It'll be in the manual, and again, it's on MoHealthNet's website as well, but we can send that link to you once we pull that up. Rate increases include self-directed services. It does under PA. So the PA rate increases for the DD waivers are for self-directed as well, for the PA service. Okay, the last one is about remote status for TCM monitoring. Okay, Jess, you got that one too. Okay, I think that's all for rates. Oh wait, here's one other one. You guys are quick. No, the support broker service is not included in rate increases.
Good question.
Yep.
Okay, thank you, Ange. Yes, and not something that we're familiar with or used to, and it is why we've taken our time with the memo regarding how the rate adjustments will work. So appreciate your patience, and did just want to say a shout out to the staff at CD, because there is some information that we got from CMS when we got our approval to use the rates, the enhanced FMAP for the appropriated rates beginning July 1st. Well, we waited until late September to receive that approval, it is our understanding that Missouri will become the first state to make payments with enhanced FMAP to providers. So that is exceptional and just speaks to the work that, first of all, the General Assembly did in getting those rates appropriated, but also the work that the team here did in order to get everything that needed to be into CMS and the back and forth questions answered in order to get that through. So just appreciate that. The standardization question is something I do want to address because rate standardization has been a goal of the division, and while it still remains a goal, it is not something that will be an attainable goal until a later date. So the new rate studies that will be coming out will reflect information about rate standardization. However, the requirements for utilizing the enhanced FMAP funding prohibits the state from lowering any rates below what was in place on April 1st of 2021 unless that standardization was included in an approved corrective action plan prior to April 1st. So a good example of that is the residential rate. There was an approved corrective action plan with a date to enhance or to standardize rates by. That's not yet, which was why there was a veto within the current budget to not standardize the rates, or meaning no one above the standardized level would be going down this year. So that is until the enhanced FMAP funding is exhausted and spent by the state, or until March of 2024, whichever is sooner. However, we have seen in all versions, the upcoming stimulus package, that those maintenance of effort requirements to not lower rates beyond what was in place at the time, we see that language in those bills as well, possibly extending until 2029. So while standardization is a goal, it may not be attainable for quite some time for those reasons. So I just wanted to let everyone know that, and we will keep everyone updated as we receive information. I think we've got some specific questions coming in the chat. I think they're all pretty much related to billing. So I think we will probably, Angie, do you want to take those now, or do you want to send out kind of a Q&A type document and follow up?
Yeah, I would, let's send out a, sure. I think we send out a Q&A document afterwards. I want to make sure everyone has a chance to review the memo. There's a lot, I think a lot of the questions kind of will be answered with the memo. So, but we'll follow up with the Q&A as well. Mary, we can answer yours really quickly.
So we'll take care of the billing questions that way. I see one more question that came in regarding receiving the enhanced FMAP, and will that only be this year? So for the enhanced FMAP that was appropriated through the American Rescue Act, it was a total of estimated $216 million, and we earned that for a full calendar year. So we'll know the exact amount that we earned at the end of that full calendar year, which will be March 30th of 2022, which is hard to say. So next March, we'll know, or slightly thereafter, when billings come in through March 30th of 2022, we'll know the full amount that was earned of the enhanced FMAP. But the state has the ability to spend that enhanced FMAP through March of 2024. So depending on the decisions by the General Assembly on how that money is appropriated and what it's spent on, will determine if that's spent all the way through March of 2024 or whether that is exhausted sooner. Beyond that. With that, I will let everyone get 10 minutes back in their day and appreciate all the great questions and interaction.